Hello, everybody. Let's continue the series of cases, and today it will be short stature and other endocrine presenting symptoms of mucopolysaccharidosis. It's a case study, but first of all, there are some housekeeping. And please do not take any screenshots. Submit your questions at any point via the question panel. Questions can only be submitted via text and not verbally. Here is my disclosures. And the case is part of this paper, short stature as a presenting symptom of attenuated mucopolysaccharidosis type 1, case report and clinical insights. We are going to talk about it. I have a short introduction. MPS 1 is an autosomal recessive rare disease caused by deficiency of alpha-L-hydroxylase and a lysosomal enzyme that metabolizes the glycosaminoglycans, GAGs, dermatan, and heparan sulfate. MPS 1 has an estimated incidence of 1 in 100,000 live births with a spectrum of phenotypes that range from severe, the Hurler syndrome, to attenuated Hurler-Shea, that is intermediate phenotype, and the Shea syndromes. Disease depending on neurocognitive involvement and the rate of disease progression. In the area of inborn errors of metabolism, that is my field of work, mainly lysosomal storage disorders, the earlier the disease manifests, the more severe is the enzyme deficiency. In the Hurler phenotype, the signs and symptoms will appear in the first months of life, very early, and the attenuated can be late, like 5 years old. It's a little bit far. The amount of enzyme residual activity will determine attenuated phenotypes, the Hurler-Shea, which is intermediate between the most severe and the most attenuated form, and the Shea phenotype. Here we can see the variability of MPS 1 expression between severe and attenuated phenotypes. The severe with a face infiltrated by accumulation of gags, thick and dry hair, bifrontal narrowing, thick lips, and the macroglossia. In the intermediate phenotypes, Hurler-Shea, the facial finds are milder when you compare with the severe one, but still have the appearance of MPS. And in the more attenuated phenotype, Shea can be very discrete and close to normal. Okay, treatment options include enzyme replacement therapy with hyaluronidase, recombinant human EDUA, and aldorazyme for patients with attenuated MPS 1 and hematopoietic stem cell transplantation with or without hyaluronidase for patients with severe. The severe cases of MPS 1, while the patient waiting for the HSCT should receive ERT in the majority of consensus, everybody agree with this, should receive ERT for the patients to be in better condition for transplantation. Treatment outcomes depend on the phenotype and the age of treatment initiation. Early treatment prior to irreversible damage can delay, stabilize, or prevent organic dysfunction and is associated with substantially improved patient outcomes. Unfortunately, is an important delay in the diagnosis of MPS 1, as you are going to see in this case, especially for patients with attenuated disease. In a study of natural history of 18 MPS 1 patients, 13 of whom had attenuated disease, whose symptoms were noted at 18 months. The mean age at biochemical diagnosis was 75 months. It's really a big delay. Male patients with history, now we are going to start the case presentation. It's a male patient with history of upper airway infections. It started at 3 months with otitis media, with a frequency of 5 episodes per year. Underwent ventilation tubes insertion at 5 years and 8 months, adenoidectomy with 4 years of age, and during childhood was hospitalized multiple times between 5 and 7 years of age for wheezing. He began experiencing hip pain at 5 years of age and was diagnosed with bilateral leg calve Perthes by an orthopedic surgeon. Okay. Patient was first evaluated by a pediatric endocrinologist clinic at 7 years of age due to his short stature and was treated with leuprolide acetate 3.75 milligrams per month between ages of 13 and 16 years. Recombinant human growth hormone, the GH, although the patient was not labeled as growth hormone deficiency between 14 and 18 years of age. And the patient presented sleep apnea through his teenagers, and at 7 years and 9 months of age was referred to a metabolic disease center, that it's my center, by a pulmonologist who evaluated the patient and suspect of MPS. These pulmonologists that take care about all our patients of mucopolysaccharidosis, that it's around 45 patients, and he takes care about these patients. When they saw the patients, he thinks about MPS. Upon examination in my center, the patient was found to have moderate joint contractures, mild facial coarsening features, scoliosis, umbilical hernia, and hepatosplenomegaly, and heart murmur. His height was 154 centimeters, z-score of minus 2.94, weight was 43.7 kilos, and head circumference was 56.5. Alpha-hydroxylase activity on dried blood spots was 0.62 micromole per liter and per hour. Reference range between 2.5 to 16.7. Urinary gags, 5.6 milligram gag mole creatinine, and the reference range was 15 to 20 years, less than 4.9, and the patient has 5.6. Sometimes in this age, the gags can be normal. And the genotype analysis revealed 2 pathogenic missense variants, R383H and the P533R, confirming the diagnosis of MPS1. Here is the timeline of assessment, diagnosis, and treatment, like a summary, what we saw. Between 5 and 7 years, hip pain, recurrent respiratory infections. We need to remember that respiratory infections with otitis media started with 3 months of age, very, very, very early. Orthopedist assessment and the diagnosis of bilateral leg calve Perthes with the 5 years by the orthopedist. And between 7 and 18 years, short stature, and pediatric endocrinologist assessment. And here he started to treat the short stature before with leuprolide acetate, 3.75, the same dose, and growth hormone, 0.1 Y per kilogram per day, between 14 and 18 years old. With 18 years old, short stature, moderate joint contractures, mild facial dysmorphic features, coarsening of features, scoliosis, and an umbilical hernia. Referred to metabolic disease center by treating pulmonologist, enzyme activity screening for MPS 1 positive, and genetic analysis confirming the diagnosis of MPS 1. And he starts enzyme replacement therapy with laronidase, with the dose weekly, 0.58 milligrams per kilo per infusion was initiated. The prognosis in patients is better in patients with attenuated phenotype because they have a bigger residual enzyme activity. Then this guy started treatment with 18 years old, and he noticed an improvement of the joints range of motion, noticed a decrease in abdominal volume confirmed with the ultrasound. He mentioned a greater disposition for daily activities. There was no progression to obstructive sleep apnea, and there was no progression of cardiac valve dysfunction. Now he is a physiotherapist, and he is the patient. We can see here some images of the patient at the time of the diagnosis, presence of kyphosis and winged scapula, limitation of the elbow, and the limitation of the joints, the knees, as we can see here. Here is the growth, Here is the longitudinal growth for patients with attenuated MPS 1 from case study. Height of case study patient by age is shown by blue markers. Let me find, yes, these blue markers, okay. And by shown by the blue markers with timing and duration of leuprolide acetate and the growth hormone and the laronidase, the aldurazyme. And as we can see, the patient maintain his growth curve below the third standard deviation. And after starting ERT, he still grew 5 centimeters, and at 159 centimeters at 20 years of age, between the third and the second deviation, standard deviation. The growth velocity of this patient, growth velocity by age, is shown by the blue markers, as you can see here. The patient had a peak after the initiation of the growth hormone of GH, and they have another smaller one when they started laronidase. Okay, here we have a table with the common presenting early symptoms in patients with attenuated MPS 1. Growth delay is one so important, not only for MPS 1, for all MPSs, normal birth weight, but growth failure or short stature. Joint contractures, primarily in hands, claw, hand deformity, joint pain and stiffness, restrictive mobility. Carpal tunnel syndrome, recurrent hernias, umbilical and or inguinal, corneal clouding, hepatosplenomegaly, skeletal abnormalities, dysostosis multiplex, kyphosis, scoliosis, hip dysplasia, flattened vertebrae bodies, OR-shaped hips, short thickened clavicles, bullet-shaped phalanges, dysplastic femoral heads, flattened acetabulum, coxa valga, and genovalgum deformities. Ear, nose, throat symptoms, recurrent ear infections, remember the otitis media, noisy breathing, sleep apnea, enlarged tongue, macroglossia, and the hearing loss. Heart murmur by the valve abnormalities, and surgical history of multiple hernia repairs, PE, tubes, tonsillectomy, and adenodectomy. It's important that you to alert about all symptoms may not be present in the same patient, but are usually progressive. See in figure the figure 2. One more data about early sign is the auditory screening failure at birth that is referred in some in a paper about early signs and symptoms of Hurler syndrome. This failed of the auditory test is important to as information. And usually we have one or more. Then you can have otitis media that start with 2 or 3 months of age, hepatosplenomegaly, and corneal clouding. It's enough to think, to remember the diagnosis of mucopolysaccharidosis. Okay, it's 1 or 2 or 3 together. We can have the suspicion of MPS 1. This algorithm is interesting because it's practical for the daily activities. Patients present with a short stature or growth delay. Then you are going to a symptom checklist, joint pain and or contractures, particularly hands, carpal tunnel syndrome, corneal clouding, hepatosplenomegaly, skeletal abnormalities, ENT symptoms, heart murmur, valve abnormalities, and surgical history. Multiple hernia repairs, PE tubes, tonsillectomy, and adenodectomy. Consider MPS disorder. You can go to the urine gag test, accumulation of gags in lysosomal, results in elevated gag in urine gags, may be qualitative or quantitative, or you can go direct to the enzyme function test. The enzyme function test is the diagnosis of mucopolysaccharidosis. Measure enzyme activity required for definitive diagnosis. In 2018, we have the last MPS International meeting with patients and people that work with these diseases. And we have a testimony of a patient, and she had do 2 exomas, and they don't find the variant, the pathogenic variant, and she didn't have measured the enzyme activity. And with more than 5 years old, she got another physician, and the physician is asked for the enzyme function test. Then enzyme, it's easier to make the diagnosis of all mucopolysaccharidosis. In summary, the case presentation highlights the diagnostic journey of a patient with attenuated MPS 1 who underwent short stature follow-up for over 10 years in a pediatric endocrinologist clinic without a correct diagnosis. And it's important to note that assessment of bone age in children with growth delay is typically done with an X-ray of the left hand and wrist. Thus, pediatric endocrinologists are in an ideal situation, being able to identify early phalangeal abnormalities as bullet-shaped phalanges typical of MPS. Look here, this shape. This is very typical of MPS 1. The alert for attenuated MPS diagnosis is not only for the endocrinologist, it is also for the pediatrician, rheumatologist, otorhinolaryngologist, orthopedist, cardiologist, and the others. And to finish my presentation, I'm going to show you editorial of this journal is Rheumatology Cambridge from 2011, and they did a supplement of all papers about mucopolysaccharidosis. It's really very good. And the Dr. Giovanni Valentino Coppa is a rheumatologist, and he wrote this editorial. And why should the rheumatologist be aware of the mucopolysaccharidosis? And I asked, and the other doctors, like pediatrician, family doctors, orthopedists, endocrinologists, ophthalmologists, neurologists, cardiologists, and ENT doctors. If we don't have the newborn screening for mucopolysaccharidosis in everywhere, only in some places. And it's so important, the role of these physicians to help these patients and make early diagnosis, because the prognosis of these patients is much better. The earlier is the treatment. And here is an example of a girl. It's the lady diagnosis of Shea syndrome, MPS 1 attenuated form, and the girl at 6 years of age, health, no significant medical history, stiffness of one finger since the age of 3 years, diagnosed with juvenile idiopathic arthritis and treated with steroids. In the picture B, the woman at 20 years old, initial corneal opacities, increase the joint stiffness, finger and shoulders, and diagnosed with rheumatoid arthritis by several rheumatologists and treated with steroids. This is a problem with rare diseases. When you put the stamp of the diagnosis of the patient, if many good physicians saw, or a good physician did the diagnosis, nobody changes. But the history of this patient, it's not of rheumatoid arthritis. Initial corneal opacities, increased joint stiffness. It's not from arthritis. And she was treated with steroids, keep the steroids. And the woman here with 31 years of age, dysplasia of the femoral head and acetabulum, echinovarus foot, dysostosis, multiplex, progressive cardiac dysfunction for valvular disease, treated for rheumatoid arthritis with gold salts and non-inflammatory drugs, and woman here with 53 years old, cardiac surgery, corneal clouding, because she did the corneal transplant, had the retinal degeneration, blindness, hearing loss, vertigo, finally diagnosed with MPS 1 by a neurologist expert in lysosomal storage diseases. Usually I use this case in classes that's not about mucopolysaccharidosis as an example of rare disease, of the lack of knowledge about MPS for the physicians. It's not the guilt of the physicians. Us, we don't have a discipline, at least in Brazil, of rare diseases in our graduation. And no professional health has this kind of approach during the graduation period, then it's very difficult. And we have old classification about the diseases between based on organs. And Dr. Saudebrey, which is the father of inborn errors of metabolism, said that this classification, the diseases are in box, like neurology box, cardiology box, and endocrinologist box. When you have a patient like this with mucopolysaccharidosis, which box is of mucopolysaccharidosis? She has neurological problems, she has ENT problems, she has cardiac problems. Do you understand? We don't have this vision during the graduation period, this whole vision about the patient, not in a box, but look the patient, look the patient and hear the history, because they are telling you the diagnosis. Thank you. Now I am available for questions and answers. So there is one question. Are upper airway infections, especially otitis media, early and very common only in the most severe form? No. The otitis media is frequent early symptom in all kind of MPSs, like MPS 1, 2, MPS 3, that you don't usually we don't see so much somatic manifestations, but they have otitis early, like 2-3 months of age, many times many episodes during the year. Then it's important not only for early patients, for the attenuated patients. It's so important because it's really early, 2-3 months of age. If you have a patient with otitis media, like every month, they need to insertion the tubes and this didn't work, you need to think about MPS diagnosis. There is another one here. What are the most common findings with MPS 1 attenuated forms? We have some publications about MPS 1 registry, and we have one publication about the Shea phenotype. And the more than 80% of the patients, the attenuated patients, at the moment at diagnosis has stiffness of the distal phalanges. Distal phalanges stiff, they couldn't extend completely the fingers. It's an important one, the otitis media, the hernia that can be early like first years of life. When you saw in the severe phenotype is in the first year of life, we have hernia and otitis, all these features. But these hands, it's so important. Then you look at the hands, and after you can look the elbow and the shoulder, and probably there is another issue in these joints. Then it's important for the attenuated patients to make early diagnosis, because they have a better prognosis, because they have a residual activity of enzyme. The response is much better for this patient. Now we have another question. What are the main differences in the evolution of patients with MPS severe and the attenuated forms? Well, the patient, the severe patient, they have the complications of the disease really early in the first month of life. You are going to make the diagnosis of cardiac involvement, neurological involvement, EMT signs and symptoms during the first between until the 6 month of age. 98%, 90% of the patients with Hurler syndrome has at least one or two of these classical symptoms, signs and symptoms. The attenuated patient, no. They probably are going to start with otitis very frequently, but only they are going to have really alert signs for the physician, like this guy with 5 years old with leg calvipators. This is alert, and it's important because it's one disease that we don't have one etiology. And if you don't know the etiology, it's important to think about any rare diseases because we don't know rare diseases. Then it's important when you have a challenge with a patient has a problem like this, leg calvipators, yet we don't know why. We need to think about one rare disease that can be any of the mucopolysaccharidosis, can be Gaucher disease, can be other rare diseases, not only mucopolysaccharidosis. Then the signs and the symptoms is going to be later. The complications is going to happen later too in the patient with attenuated phenotype. There is one question about, would you give GH to all MPS patients? No, for no MPS patients. It's not the conduct. We have some papers about, and in general, we don't have a great success with the GH therapy. We saw a good result in this case, but it's not a conduct that you extend for all patients with MPS. If you look, you can read some papers, and nobody, it's not a consensus to give GH for mucopolysaccharidosis patients. Thank you for the question. Did the girl in the presentation responded to growth hormone? Well, in the case presentation was a boy, and the boy responded. He gained some centimeters during this period. But as I said, it's not a consensus. Does the use of growth hormone increase or worse kyphosis? I think so. I think is worse for the kyphosis. Well, how do you clinically differentiate MPS 1 and mucolipidosis mild type? Well, we have some similar characteristics, but the best way to distinguish it is doing the activity, the enzyme activity measure, the enzyme activity of this patient. We have twins with mucolipidosis, and they start the investigation as mucopolysaccharidosis, and we find out the diagnosis because it's not everything from MPS. MPS is very peculiar, and they are similar in the facial aspects, the gingiva, that we have hypertrophy, and But the best way it's really to do to measure the enzyme activity. I know Shay is autosomal recessive, but to you, Shay, more in girls? No, no. It's I have well, I have more girls too, but we have more girls in every disease because we have more girls in the world. But it's not nothing was published about this. Curiosity. I have more girls with MPS 1 attenuated phenotype like Shay. I have one boy, one girl. For MPS 1 is the same, it's 50%, boys and girls. Low enzymatic levels in 2 tests with EDUA gene in heterozygosis in molecular. What is the next step? Well, you can measure the urinary gags, but if you have a low enzymatic levels below the reference value is mucopolysaccharidosis, or you can have, maybe you can check mucolipidosis too, or multiple deficiency of multiple sulfatases. You can try to, but if the enzymatic level is below the reference range, you are having one patient. And sometimes, like I told about the testimony of the girl in the MPS international meeting of patients, and she did 2 exons, and they didn't find the 2 mutations, only on one variant, not 2. And she has mucopolysaccharidosis. The enzymatic measure, it's the most important exam for mucopolysaccharidosis, because sometimes the urinary gag is negative. If it is positive, it's okay, wonderful, can help us. But if it's negative, they not good. You couldn't exclude the diagnosis. One more. No further question. Thank you so much for the questions, for the attention, and I hope to see you in another occasion. Bye-bye.